It is now 11 o'clock, so we will get started. Thank you all for joining the Georgia Department of Public Health Strike and Support Team Office Hour. My name is Maya Labat, your host for today's event. Please keep in mind that this event will be recorded, and we will drop in the link to the slide deck in the chat. And I'm going to hand it off to Melody Brown from Alliant.
Thank you, Maya. And again, thank you everyone for joining us today. We're going to get started. We have a full agenda today, so we're going to go ahead and get started. Maya, for the next slide. Our presenters for today will be Dr. Swati Gar, Teresa Fox, and Regina Howard. So we'll just keep going through the slides until we get to the actual presentations this morning, Maya. The next slide. We want to thank back one, if you don't mind, Maya. I'm getting ahead of myself just a little bit here. We do want to thank our partners, for without them, we could not be bringing this presentation to you today, the Georgia Department of Public Health, as well as the University of Georgia. Next slide. Our purpose, as always, is to keep you up to date with the relevant activities going on in infection prevention, as well as bringing you new tools and resources, which we will do today. Regina and Teresa will do from the Georgia Department of Public Health, as well as Dr. Gar on updates for COVID and other relevant activities going on throughout the state of Georgia. We do have in September support with strategy to reinforce staff importance. We know that a lot of things have been going on around your staff and staffing, so we want to bring you some opportunities and ideas around that, and reinforcing the importance of staff as related to infection prevention. In addition to that, we have set the dates for upcoming training, and these will be our large trainings for skilled nursing facilities. So if you will block off time on October the 25th and the 27th, we will get those times for you, but the mornings and afternoons, we'll have a 4-hour session on the 25th and about a 2-hour session for respiratory training on the 27th. So we will be getting those dates and times out to you very soon, but just block them off if you don't mind right now. And we will have CEUs that will accompany those trainings. Your opinion matters, so at any time during this presentation today, please drop your thoughts or your questions in chat, and we will try to get to all of the questions, and we will have a Q&A session at the very end as well, but continue to drop your thoughts as we're going through today in chat. We want to make sure that you're aware of a package that will be coming to you from the University of Georgia this fall through this grant that we're all working on. In next slide, let me tell you what's going to be in that package. Just keep on the lookout. 500 Georgia facilities, including all skilled nursing facilities in the state of Georgia, will be receiving a package. The box will contain all 9 of the elements as you see on the right-hand side, to include a large APIC long-term care manual, a GlowGerm Lite, some NHSN data packet, rounding checklist. All of this information will be coming to you in a package, and so we want everybody to be on the lookout for that. It will be coming from the University of Georgia, their Georgia CNA Career Pathway Initiative Center. Next slide. In addition to those resources, you will also be getting about 2,000 facilities. As a matter of fact, we'll be getting a new N95 fit test kit to include videos for how to administer and test folks for N95 masks. Next slide, please. We want you to join the UGA or University of Georgia on their social media accounts. So all of these will be available for you. And as Maya said, we'll be dropping the link in chat again so that you can have not only the recording of this, the presentation today, but you'll have all of these links that you can join. But again, we want you to be on the lookout for the box. We don't have a date yet. Some of the materials they're still waiting for, but we hope late September these will be coming in. I want to tell you about another program that the University of Georgia Institute for Disaster Management is actually going to be doing coming up pretty soon. This is under a different grant, a Civil Money Penalty Fund grant or CMP fund grant. So just know that this is different than any other, the strike team or the information that I just gave you from the University of Georgia, but want you to be aware of these trainings and educational program. Next slide, please. So this is again, a 3-year funded program by the CMP funds. It started in 2021 and will go all the way through 2024. Courses are open to all certified long-term care staff members, clinical and non-clinical. And again, we have a website here that you'll be able to get whenever you pull these slides down. Next slide. The year 2, which is what we're in right now, will have 14 principal courses that are going to be offered between September of 2022 and April of 2023. They're in person right now. We're going to give you a list in just a minute of where these in-person education opportunities are. It is subject to change due to any activity with COVID-19. Next slide, please. So this is a list of all of the locations that the trainings will be. And you will have this again whenever you click on the link for the slides. This will be in there so you can go out and register at any of these opportunities that you or your staff would be interested in for this extensive training. Again, this is through a CMP funded grant via the state of Georgia, CMS, and administered by the University of Georgia Institute for Disaster Management. Next slide, please. Here is the website for that you will have. You've got a couple of links here that you'll be able to go out and ask questions if you have any questions around this training. Next slide. And at this time, it is my pleasure to turn this presentation over to Dr. Swati Gar. Dr. Gar, take it away.
Thank you, Melody. All right, so we're going to do it fast because I know that there's a great program on infection control and cleaning that is right after we talk. So I'm going to just set this up for them. Where are we with COVID? Next slide, please. So I update these slides. This is the resident cases of COVID-19 in Georgia per the NHSN data. And this is the latest data. And as you can see, there's that slight uptick at the very end. So, you know, we are still in it. Next slide, please. And the resident cases, I always say we don't keep COVID inside the building. It comes from the outside right now, depending on where you are in Georgia, your community prevalence of, remember when we used to do those percentages, is about 30%, 25 to 30% in the state of Georgia, depending on where you are. So it's pretty high. And the staff members, this is the staff cases. So the staff members live in these communities where we are seeing pretty high prevalence of COVID-19, and they come in, they test positive, and the residents test positive. The other thing that we are seeing also is with that visitation being, you know, a little bit more relaxed. Family members are coming in, they may or may not know that they have COVID. You know, the symptoms have changed, the classic symptoms of, yeah, I'm coughing a lot, I have fever, don't feel good, has changed. So what we are seeing more is a runny nose, a sore throat that people are not typically correlating with COVID. So it is incredibly important for us to make sure that you have a good visitation policy, which means that it is important for nursing homes to let the visitors know that, especially during this time, during surge times in the communities, COVID is at a very high rate in the community. You may or may not know if you have COVID, and it is very advisable for the safety of your loved one to be wearing a mask when you are doing that one-on-one visit. I know that, you know, the regulations say that we cannot mandate them to actually wear a mask when they're just only with their family member, but it is a good idea to tell them that this is a time that they need to be cautious for the health of their loved one. And certainly they should not be jeopardizing people, other people in the building. So all visitors are supposed to wear a mask and follow infection control processes. Next slide, please. All right, so this is the wastewater surveillance. Again, you know, these data are like a patchy snapshot of what is going on. So we always look at the wastewater surveillance. And what we want to see is more of those deeper blue dots that we are not seeing in Georgia, but what we don't want to see much is the red, the bright red dots, and the orange and the yellows, which means your last 15-day levels of COVID have gone up. And what we are seeing is in Georgia that there is that orange dots and especially in North Carolina and Northeast Georgia, there's that orange dots that we are seeing. So we are kind of still in the middle of it. All right, next slide, please. All right, this is important. So I did see, this is the slide set I had sent on Monday. What we are seeing here is most of our COVID-19 is coming from the BA.5 variant. And as of today, I went in, as of today, it's at 88%. It looks like this is at 86% last week. And as of today, it is 88%, which is, it's kind of almost occupying the whole variant list. The other variant that we need to look out for, because we're always looking, what is up ahead on the road? It's like driving a car. What is up ahead? Well, what is up ahead is BA.4.6 variant. And as you can see, that the variant itself is going up. So it was initially BA.5, BA.4, and then this little BA.4.6 started sneaking in. It is crowding out the BA.4 variant, and it is starting to increase. With the proportion is starting to increase. So we expect that this is the more contagious one, and we expect that that's going to be the next one to possibly take over. So we're just keeping an eye out and making sure that we are keeping track of what we are dealing with right now. Next slide, please. So what do we know about the BA.4.6? It's moving faster. It's gaining that, the variant share more. So if you actually look at the growth of the variant, what BA.5 is doing is kind of plateauing out. What BA.4 has started doing is it went up and now it's coming down. What BA.4.6 is doing is a straight up. So it is starting to kind of crowd out the other variants in the community. What do we know about it? Well, it's about 15%, 15 to 20% in the Midwest, depending on where they are. Symptoms. Again, the symptoms are being seen more in the upper respiratory area. So runny nose, sore throat, cough, fever, body aches, fatigue. If somebody is having fatigue, they're just not feeling right. It's important for us to ask our staff to kind of check for COVID, because it is all over in the community. If somebody says to you, oh, I think I have a strep throat, likely with whatever is going on in our community, the first thing we need to think of is, let's do a COVID test. It's more likely a COVID sore throat. So just let's keep an eye out. It is not going to be, I'm short of breath. It's not going to be, I'm dropping my SATs. It could be, but that's dangerous. Most of the symptoms are what you're seeing is that runny nose, sore throat, cough. You need to make sure that your staff, when they are doing surveillance, they are aware of these symptoms, because we don't want to miss it. It moves fast. It spreads fast. If you have two people in the same room and one of them has it, the other one will have it. It moves very fast. So you got to be careful about recognizing it early. Next slide, please. All right, so what is our COVID-19 strategy? One is keeping the outbreak out if it is possible. And second thing is, even if you did have the outbreaks, to keep the numbers down. The other strategy is to keep the resident himself or herself safe. So those are the true strategies as a nursing home that we need to have, or assisted living. Those are the two things that we need to be able to affect. So how are we going to do this? Next slide, please. All right, so these are the latest studies, and this is during the Omicron time. So all this data is during Omicron time. And the studies basically are showing that against Omicron, the vaccine effectiveness is 70%, which means 7 out of 10 times, it, if 10 times there is an exposure, 7 out of 10 times, it's still protecting the person from actually getting the disease. Those 3 out of 10 times are the breakthrough cases. Now with BA.5, it has gone down just a tad bit, but let's say if 6 out of 10 times it is able to still protect that resident from, 6 out of 10 is a good chance. So make sure that your residents are up-to-date vaccinated. This is 3 doses of mRNA shots that were, so they had that first booster in. Hospitalization advantage. Hospitalization advantage is 90%. And with the BA.5, the latest studies, which I'm going to discuss in a few minutes, is showing about 80%, 77 to 80% hospitalization advantage. That's pretty cool. So again, keeping the patients from getting COVID, boosters help. Getting the patient from going to the hospital, boosters help. To a larger extent up here to keep the patients actually from getting that super sick and going to the hospital, it does help. Mechanical ventilation or death, about 90% with BA.5. Next slide, please. All right, so this is another study that was published in MMWR. If you were just the primary series, which the dashed are the primary series, the long dashes, and the dots are the boosted people. If your residents in the nursing home have only had primary series, most of them, then your cases are about 12, if you, and that is per 1,000 resident weeks. But if you have everybody boosted and up to date, you cut down those cases by half. So if you remember, what is our strategy? Keeping the disease out of the nursing home and keeping the numbers down. So the higher your booster rates are, the lower your numbers of outbreak are going to be. So this is an important strategy. Next slide, please. All right. So that's why, while it's very important for us to make sure that our PPE and infection control is at the top, and early testing, making sure that staff knows what the surveillance signs are now, runny nose, sore throat, etc., and do early testing, early cohorting. That is important. But our main thing is still, our main strategy is vaccinate, vaccinate, vaccinate. Let's bring down the numbers. If we did have an outbreak, let's bring down the numbers. And second is, let's keep them from getting to the hospital. Let's turn this deadly illness into just another viral infection. That's what our strategy is. And that's why we are big on vaccination. Next slide, please. All right, so this is preventing spread. Two things, important things. Make sure that your staff has boosters and is up-to-date vaccinated. Why? They will have a lower chance of getting it. They will have a lower chance of passing it on. And then your staff is wearing N95, especially during the outbreak time. That is important. Families, make sure that you counsel them on getting vaccinated, and definitely very strongly counsel them on wearing a mask when they are interacting with anybody in the nursing home, even their loved one. Other residents, vaccinate them up to date. They will have a lower chance of getting it themselves, and they will have a lower chance of giving it to other people. Next slide, please. All right, third dose versus fourth dose. This I get all the time. I got my first booster. Do I need my second booster? Well, here is a study out of Israel. The left top tells you the advantage of getting that second booster. The orange line is the number of people who got the second booster, the number of COVID cases in people who got the second booster. The top line, the green one, is the one who got the first booster. So certainly there is an advantage in new cases if you did get the second booster. The advantage gets bigger and bigger the right one is hospitalization for mild COVID, mild to moderate symptoms of COVID. The bottom on the left side is severe COVID, and the last one is death. You can see that the magnitude of advantage just keeps increasing for severe disease and death. So significant advantage with that fourth dose compared to only the third dose. So that's an important consideration. Next slide, please. All right, so this is a new study that came out for vaccine effectiveness against BA.5, and as we have discussed, about 80% in hospitalization benefit, about 90% death benefit. So huge benefit of having up-to-date residents against BA.5 as well. Next slide, please. All right, this is an important slide, and I want to really discuss it very quickly. I know that we have vaccination efforts going on. The flu strain that we anticipate is going to take over this fall is H3N2 variant. It can cause severe illness in our vulnerable elderly patients. While you are giving your COVID shots, you can actually, as soon as the flu shot time comes around, you can start giving flu shots as well. So prepare, anticipate, and you can do it the same day. So get your consents and everything, get the logistics laid out where you can give one arm COVID shot, one arm flu shot. COVID shot can be co-administered with pneumonia shots and flu shots. Make sure that the arms are different so that you know like which side you gave which one, because they will have some aches and pains on either side, but they can be given together without any problem. The other thing that I did want to mention again is Novavax. It is a newer vaccine, and just in case you have not heard about it, this is an important vaccine in people who didn't want to take the mRNA vaccine. So what we are doing now is families who have refused the mRNA vaccine for whatever reason, several of them have refused it for religious reasons. Novavax is the COVID vaccine that is exactly like the flu vaccine. So the flu vaccine that we are used to taking every single year, its sister for COVID-19 is the Novavax, made exactly like the flu vaccine. There is no mystery in there. There is nothing new in there. So that is the alternative that you now have available for your residents who have taken the flu vaccine before but have refused the COVID vaccine. You do have that Novavax available that you should be going in and offering because of that significant advantage that you are seeing when your patients are vaccinated. Similarly with staff, if your staff has taken the flu vaccine in the past and have not taken the COVID vaccine for religious reasons, somebody is going to question why you didn't offer the Novavax, because Novavax is the flu vaccine for COVID, literally. So that is an important consideration that you need to now go back and discuss with the staff and discuss with the residents. Just a bivalent mRNA vaccine was approved in the UK. We don't have a date for when our FDA is going to look for it, but I'll keep you guys posted on that one. Next slide, please. All right. If you are having an outbreak in your nursing facility, when that person goes into the COVID unit, even if they have mild symptoms like body aches, mild fever, sore throat, runny nose, any symptoms, our patients are highly likely to have poor outcomes. Age is the #1 factor. Always consider if they are eligible for Paxlovid, remdesivir, or molnupiravir. Or the monoclonal antibody, which is bebtelovimab. That's the only monoclonal antibody currently that we have approved for the current variant. But the first thing that you have to consider is, are they eligible for Paxlovid? And discuss with your consultant pharmacist, because you want to make sure that their renal function and their liver function is okay, and their some of the medications have to be put on hold, like cholesterol medications have to be put on hold to start this. So make sure that your consultant pharmacist is well aware of this as your patients keep testing positive. Next slide, please. A lot of people are worried about long COVID syndromes because they are seeing that, you know, this illness may not be as acute, as dangerous for people. However, people are still suffering from long COVID syndrome. 1 in 3 people will have long COVID syndrome. Vaccines are effective in preventing long COVID syndrome. Vaccines taken either before you get COVID will protect you from having long COVID. Vaccines that are given even after, or you know, before and after. So if you gave the first shot before and now you're giving the second shot after you got COVID, still effective against protecting you. It's still going to protect you from having a long COVID syndrome. Or if you took the primary series after getting COVID, it's still going to protect you from long COVID syndrome. That is an important consideration that our staff needs to know. Next slide, please. All right, always prevention is better than cure, but cure is there as well. So always consider that. Your 2 goals: keep the outbreaks down, keep the patient safe, and keep them from getting super sick. So you have vaccines for this, vaccines and PPE for this, and infection control, and vaccines for this, and medications for this. So always consider that. Next slide, please. All right, this is queuing it up straight to infection control. So I'll
Dr. Gar, and we do appreciate everything that you have presented today. Just know, everyone, I've dropped the link for the slides so far that Dr. Gar has, well, the whole slide deck, over in the chat function. So you're able to pull down all of these graphs and all of the information that Dr. Gar has shared with you today. If you want to share that with your medical director, your pharmacy consultant, and your family, staff, anyone in your nursing home, you have that available. So without any further ado, I'm going to turn the presentation over to Regina and Teresa. And Dr. Gar, thank you so much for always being with us.
Good morning. My name is Regina Howard, and I am an IP with the Georgia Department of Public Health. And I will be speaking to you today relevant to cleaning and disinfection. Next slide, please. To prevent the spread of COVID, we drill this in you quite a bit, I'm aware, relative to hand hygiene, but it's a low-tech process, and sometimes it's very difficult to get others to do it. But hand hygiene frequently is very important. We would also like you to be cognizant of the fact of touching your face. Sometimes unconsciously, we touch our face, and if our hands are not washed, we can give ourselves COVID or other infections as well, and give it transferred on to others. Regularly disinfect surfaces and items touched. Distance yourself from those who are coughing and sneezing. Cough and sneeze into your elbow or a tissue, and dispose of tissue promptly. This poster next to it shows how we touch our face, we touch our eyes, unconsciously, unaware. And when you're touching your eyes, you're in contact with mucous membrane, and that's how you can transfer organisms to yourself and to others. Next slide, please.
And Regina, could you speak just a little louder for us, please?
Oh, I'm sorry.
Thank you.
Sure, no problem. This is a poster indicating how often we touch ourselves and not realize it. We touch our eyes, our ears, our mouth, our hair, and this also indicates how many times per hour we're doing this. Next slide, please. Pillars of COVID-19 prevention and control. Although, again, we stress hand hygiene and transmission-based precautions when appropriate, this talk will be emphasizing environmental cleaning and disinfection. Next slide, please. Why clean and disinfect environment and shared medical equipment. First of all, we'd like to prevent transmission of organisms to residents and staff. Also, to protect those whose immune system is incompetent. Also, to provide transmission of COVID-19 and to prevent transmission of COVID-19 and multiple drug-resistant organisms. And we also would like to provide an aesthetically pleasing environment. Next slide, please. Indirect transmission of germs. Germs can survive for up to 3 hours on your hands, believe it or not. And we have a poster here that indicates how long the coronavirus is prevalent on various surfaces. So if you look at glasses, for 4 to 5 days, the coronavirus can be present on glasses if not properly cleaned. Aluminum cans, 2 to 8 hours. Latex gloves, less than 8 hours. So it's very important that we clean our surfaces effectively to rid ourselves of organisms. And on the right, you can see how long organisms live in the environment. Next slide, please. Okay. High-touch surfaces require daily and frequent cleaning during outbreaks and high community transmission. This is why when we're talking to facilities, we stress to them how important it is to clean high-touch surfaces at least 3 times a day. And those surfaces include doorknobs, bed rails. These are called fomites. These are things that people touch on a regular basis many times during the course of the day. COVID mainly spreads from person to person, but it can also be left on objects and surfaces. If you look at the poster and you see the fomites that I've been talking about, the doorknobs, the keyboards, the mouse, the desk handles, pens, and so on and so forth. Next slide, please. Daily cleaning of residents' room. There is a proper way in which residents' rooms should be cleaned, and that should be either in a clockwise motion or a counterclockwise motion. It also, proper cleaning is done from top to bottom and from clean to dirty. So that's the way in which, when we enter a resident's room, how we should do our cleaning process. Clockwise, top to bottom, clean to dirty. Next slide, please. This is a nice poster, and it indicates how hand hygiene should be performed prior, at the beginning of whatever it is you're doing, and after you've completed those tasks. Next slide, please. Cleaning of shared medical equipment. It's very important that the facility develop a policy and procedures for cleaning and disinfecting. This policy should be clear on who is responsible for the cleaning. That should be made very clear to your staff. It should be documented so there's no error in thinking, well, someone else cleaned it and you just assume it's been cleaned and it has not. So that's why it's so important that you state that in your policy exactly who is responsible for what cleaning. Also follow manufacturer's recommendations and establish a method for assessing the quality of cleaning and disinfection. Cleaning products should be available at the point of use for your staff as well. Next slide, please. Storage of clean equipment. All items should be cleaned and disinfected prior to storage. Store clean items separate from dirty items. Store in a clean, dry, well-maintained area. The area should be clean, clearly identified for the purpose. Develop a facility-wide system to identify clean and dirty items. If you will look to your right and see the floor, this was a clean storage area in a facility. Look how dirty it is. That is not where you want to store your clean supplies. Also next to it, we are looking at a piece of equipment there, and those are hand guards, I imagine, on that equipment. You see the stain on the hand guards? This is supposed to be clean equipment here. Also, look at some of the paint is peeled away from that bar as well. When you have crevices like that, you cannot properly clean equipment. If you see the paint has been, I don't know what's happened to the paint. Anyway, it allows crevices and cannot properly be cleaned. So you cannot have equipment like that in a clean space saying it's been cleaned and disinfected. It cannot properly be done when you have peeling paint on your equipment. Next slide, please. Two-step method. Cleaning and disinfection are two separate methods. Cleaning is removal of dirt and body fluids and other organic matter, accomplished manually or mechanically, using water with detergents or enzymatic products applied with friction. Cleaning reduces the presence of organisms, preventing harm when the surface is touched. It does not kill germs. Cleaning is mandatory in preparation for disinfection and sterilization. Now that we've done our cleaning, we go to disinfection. The process of utilizing EPA-approved chemicals that eliminate or kill many or all pathogenic organisms, except bacterial spores on surfaces. Products used in hospitals and other healthcare facilities are referred to as hospital-grade disinfectant. Disinfection is used on inanimate objects and is done after the cleaning process. Some of the facilities are utilizing ultraviolet lights. They're also using hydrogen peroxide spray. And all surfaces prior to use of those products must be cleaned and disinfected prior to application. Some people are utilizing the ultraviolet light and the hydrogen peroxide spray, thinking that's going to do the entire job. It's going to clean, it's going to disinfect. That's not happening. That room has to be cleaned and disinfected prior to utilizing those products, ultraviolet light and the hydrogen peroxide spray. So don't be misled that that's going to do the entire job for you. It is not. Next slide, please. EPA's list of effective products. EPA reviews laboratory testing data and assigns a primary registration number, usually at the bottom of the back label on your product. Select EPA registered disinfectant. This is the website for that. And we have 3 listed here, list K, list N, and list P. List N is specific for disinfecting against SARS-CoV-2. I would recommend in orientation that you would bring some disinfectant products and allow your orientees to look at the label. This way they become accustomed to reading labels. So perhaps make that a part of your orientation of new staff. Next slide, please. Here are disinfectants. These are sample labels that you can make a part of your orientation process. So be creative in orientation. Let it begin here where they begin reading labels so they become, your new hire will become accustomed to reading labels. Next slide, please. When using disinfectants, of course, follow the directions. Use the recommended PPE when cleaning and disinfecting. Ensure adequate ventilation. Dilute products per manufacturer's instructions. Preferably, your staff should not be required to dilute products because who's to know the dilution is the proper proportion. So I'm not highly recommending having the staff dilute products. So if you can possibly get away without doing that, I would highly recommend. Label diluted cleaning or disinfectant solutions as directed by OSHA. Use water at room temperature unless otherwise stated on the label. Do not apply cleaners or disinfectants directly on the skin. And speaking of that, I would have the SDS available as well for my staff. And that's the safety data sheet. It tells you what to do if you have a spill on the skin regarding whatever it is that you're using. So that's also an important part of the process. Do not apply cleaners or disinfectants directly on the skin. Do not mix different products or chemicals. Perform hand hygiene after glove removal and store in secure location. Next slide, please. Contact time, wet time, and dwell time. Many times people confuse the issue here. Time the disinfectant is the time the disinfectant needs to stay wet on a surface to ensure efficacy. It is determined by the manufacturer and based on the results of microbiological testing using EPA-approved methods. Provide adequate time for room turnover, taking into consideration contact time, dwell or wet time for disinfection to occur. So give your staff enough time to clean that room because they need that time to properly utilize the disinfectant. A dry environment may cause faster drying of the disinfectant, and reapplication may be needed to allow for full contact time to occur. This is another thing that you should probably stress in orientation for your new hire. And always know the contact time for the product in use. So again, be creative in orientation. Bring some of the products that are utilized in your facility and allow your new hire to read the labels. Again, this way they become accustomed to reading the label. And when you have an inspection and they're questioned, they remember exactly what it is that they're to respond. So again, always know the contact time for the product in use. Next slide, please. That's it. Thank you.
Thank you, Regina. I'm Teresa Fox, and I'm going to talk a little bit. Regina has talked about how, when, and why we do things. And now I'm going to talk a little bit about the quality part of cleaning, which is so important. And so let's start. Next slide. So when you talk about, you've heard Gina talking about how important it is to know how effective your cleaning is. So let's begin by saying direct visual assessments after a room is clean can only assess the visible cleaning or cleanliness of that room, such as was organic blood and other products removed, was there no dust, but it cannot evaluate the bacterial load or the decontamination on those rooms. So visual assessment alone is not adequate, and another method for necessary surface cleaning should be, and we will recommend that you do that. Direct observation can be done covertly and with your housekeeping, assessing the actual cleaning and provide an assessment of how well your staff adhered to your policies and procedures that were outlined. The second method we talk about are fluorescent markers, and that practice is used to monitor the effectiveness of at least it was hit. It can't make sure it killed all the germs, but they use these. They are inexpensive and they're easy to implement and use, and they do provide a quick, immediate feedback to your staff. So what you would do is you would take a certain product, you would go in and covertly mark areas in that patient's residence room. And then you would go in with the housekeeper, and after they clean that room, then you would go back, turn out the lights, turn on a UV light, and then you can discuss areas that was missed and go through the process. And it's a really effective feedback and educational tool. You know, and you can see in this graphic to the right, it shows you all the areas that need to be cleaned and where you could apply your markers. And the good news, as you heard earlier when Mel was talking, that GlowGerm, which is one of these UV markers, will be included in the UGA toolkit that will be coming your way. The instructions on how to do the particular methods for them is included in the kit toolkit box with the GlowGerm. So be sure to look at that. If you have any questions, we will be available to help you and assist you with those things. Next. This one, we talked about checklist, and this is a housekeeping daily checklist audit that the DPH team has created. You can see it's pretty in depth, you know, and it will also be in your Georgia toolkit. It should be in a form that you can edit, add two things that you think that we might have left off that's important to you, or you can remove things if you think that's necessary. These are, you will notice in the bottom that these are considered quality improvement tools. So make sure that you keep that statement on the bottom, and we won't go through, it's too small to read, but I just wanted you to know that that tool was going to be in the kit. Next. Next slide. Hello. I'm having issues.
Hold on one moment, Teresa. It seems like we're having
Okay,
an
I
issue
didn't
with
know,
it.
I
No,
lose my internet from time to time. I was just wondering if I'd lost it.
no, we have an issue. Just a moment, a technical
Okay,
issue.
that's
Just
fine.
please, if you want to continue on discussing, that will be fine, and then Maya will catch up.
Okay. So, well, I can't. The next slides are just visuals. But it's very important that you take time not only to train your housekeepers and other people in your facility. You ought to audit them, not just your housekeeping people, but anybody that does any form of cleaning and disinfecting should be included in your audits. And we have included one of the things that we will be talking about here in a minute is an audit tool that we have provided that will also be in that kit. And that tool will give you an opportunity to audit your hand hygiene, and it will give you an opportunity to audit your PPE application and use. And then the third one will be cleaning and disinfecting. And what we tried to do was combine all of those things onto one audit tool. The instructions on the audit tool will
And Teresa, just keep going. We're trying to edit in the background, okay?
okay. So the instructions on how to use that particular tool will be at the bottom of the instruction sheet. So it's not a separate sheet. It's really easy to use. And what we ask you, you know, for any statistics to be valid, you need to have at least 30 observations in whatever time frame that you're going to calculate your compliance rates are. So these are set up for you to get at least 30 per month, and for you to calculate each one of those. And then my understanding is that Alliant has conducted an educational opportunity where they taught people how to use an Excel spreadsheet to do grafting and calculations. And this tool that we're including in the toolkit is set up to use Excel. So any tool
Teresa,
that
I
you
can
see,
I can tell you the next slides if that will help you. I can tell you the titles. Will
okay,
that help you?
if you can, I
Okay, so
can't
the
get
next
to mine.
slide is auditing and sharing of data and performance improvement project, shared non-critical
Okay, let
equipment.
me just talk about what that project is. You know, I'm gonna give you a little background. Y'all all know I came from acute care, and one day I was up on the floor, and our housekeeping people were cleaning a room, and I walked in, was just gonna observe what Regina was talking about, the patterns for cleaning, top to bottom, just to make sure all of those things were being properly done. And there was an IV pole sitting over to the side, so they were getting close to being finished, and I said, "Oh, who cleans that IV pole?" And the EVS person said, "Oh, that's nursing equipment. Staff cleans that." So I went to the nurse's station and found me a nurse, and I said, "Hey, IV poles that are up here, who cleans those?" She said, "Well, EVS cleans those before they take them back down to storage." And I thought, that explains why this IV pole looks like it does. It was very, very dusty. There was all kinds of stuff on there. It was not being cleaned. So we all know that CMS requires that we do a performance improvement project. And they love for it to be for you to have an infection control one. So when you go down to where, okay, you could.
And
So what I'd
Teresa, I
like for
have
you,
to ask, can you see my slides now?
I can see your slides.
All right, we are so sorry for the technical difficulties today.
Go back
Uh,
up to right there where it's got the PDF. We talked about that one. Go to the next.
Okay.
Yeah. All right. So I can kind of summarize this. You know, when we're doing a performance improvement project, or anytime we're auditing anything, it is very important that we share that information with our staff. If you collect all this data and it sits in your office, and then once a quarter you have your quality improvement meeting and you take it out to your quality improvement meeting and they say, "Oh yeah, here we are," you know, same stuff. That's really useless, because you guys are not the people that are going to have to make the improvements. It's very, very important that you share your data with your staff. And when we talk about this, you will say, "I noticed graph data cleaning, report monthly averages." But the graph that we're going to talk about, which is also set up in Excel, shows your staff where they're improving and where they're not improving. And lots of times I have gone to quality, people, long-term care, where they're doing their WAPI meetings, and they'll say, "Oh, our hand hygiene compliance this month was 85%. Oh, that's good. Well, you know, what was last month? What was the month before that? What is your goal for that hand hygiene? Do you really want to be at 90%? Then how close are we progressing to that?" Next slide. Yeah. So here we are, and this is where I was talking about the improvement project. So you can actually do it for non-critical equipment. So what you would do is you would gather a multidisciplinary collaborative team. This is not someone that sits, the administrator, the DON, and the IP person sits down and does this project. This is a facility-wide project. So what you do is you develop a system for identifying clean versus dirty equipment. I don't know how many times I walked through a nursing home and I will see a Hoyer lift and a sling through over it. You know? So when I ask the staff, is that a clean sling? Because those have to be changed between every resident unless they have their own, which should stay in their room. And I get this deer in headlight look, you know. Well, even if it's supposed to be clean, how do you control residents and other people touching that sling while it's just parked there? So you need to have a system so that anybody in your facility can say, I know that's clean. For example, it's in a clear plastic bag and it's hanging on the Hoyer lift. That means it's clean. Okay? So you got to have a system. So you develop with your team what that system is going to be. The next thing your team is going to do is you're going to develop a goal for that compliance. And in order to make a goal, you're going to have to conduct a baseline compliance audit. You just covertly go around your building and look to see what percentage of your equipment is really being cleaned and cleaned adequately and quality. So you get that baseline so you know where you are when you start. And then you go in and you take your team and you sit down and you list every piece of shared equipment in your facility. Not just wheelchairs and beds, but down to the point of we share stethoscopes and nurses do to do blood pressures. You list every piece of equipment. And I don't just stay with your clinical nursing. Remember, you have shared equipment in physical therapy. You have shared equipment in dietary carts, trays. You have shared equipment from your speech therapy. So make sure that you're covering all the entities, right? And then you create a list, and I'll show you kind of what I think that list should look like. You establish who's responsible for the cleaning. Sometimes, like a wheelchair, it would be your CNAs between each use, but quarterly or monthly, your maintenance people should take it out and power wash it. You get down to that kind of detail. And then you create a schedule for those activities, and then you can use it for your staff assignments. And then you create a chart, and that's what I'm going to show you. And then you educate your staff. You can't expect people to do things that you don't educate and define what their responsibilities are and what is the process for maintaining it. And then you're going to post and distribute these charts to all involved staff. And we always have surveyors that come into a building and they walk up to your housekeeper. And first, I'm nervous. I'm not going to be able to think very clearly about what my answer should be to them. And as a person that's in a lot of buildings, when I ask that, if I get this blank look on their face, I'm thinking, that's something they should know. It causes me to dive deeper. And my old adage is, don't ever have anything on the surface that's going to start me asking questions. Because when I start asking questions, then I'm going to get down a rabbit hole. Okay? So you have it very clearly. And one other purpose, you could take that chart, give it to every housekeeper, and you will notice when I show you the chart, every one of the products that we select to use, we're going to provide them the wet time. So all they have to say is, this is a, say, a IV pole. This IV pole is cleaned. This is what I clean it with. This is the wet time, and this is the product I use. It takes that anxiety, and when they do that every day, then they're going to know it verbatim so that's a good way to encourage your staff. And when you're doing audits, make sure that they are following all those. And anytime you see things that are not happening, then you do immediate interventions at that point. And when I talk about all those things, it would be great if we could, do those and look at them and proceed on down. Next slide. This is my idea of what a shared non-critical equipment list should look like after your team has sat down and created. You know, I have what the equipment is. I have down there what method of disinfectant we're going to use, who's responsible for it, how often does it get done, and what is the wet time for the product that we selected. There will be a edible form of this non-shared equipment in your toolkit. So these are just examples, but it will give you an idea of where you should start to do that project. And, you know, we all do projects all the time that we're required to do. And my adage to those is don't ever collect a number that you can't find something to do with it. So this is a PIP project that you would find very beneficial, I think, to your facility. Next. This is the auditing tool that I was talking about, and yet there's a copy of this one, and you can see it set up for hand hygiene, PPE, and shared equipment. I know there's 5 moments for hand hygiene. Some of those you're going to have to do just observations while you're doing other things like wound, okay? But if we can, these major opportunities, if we could get really good compliance with these, you would be amazing at the reduction in transmission that you would have within your building. Next slide. This is what I was talking about when you take the previous slide, and I just happened to select cleaning and disinfectant for non-critical equipment. So we did our baseline, and then I set a goal, and I set our goal to be at 90%. So that's what that green line is across there. And then the blue line is what was my actual compliance. Yeah. And then the red dotted line. And if you don't know how to put a trend line in, that's something I can help you with. But that's really what you're looking for. You've got ups and downs in your data, but your overall trend should be in the positive direction. Very easy to do. If you can do basic Excel, then you can do these kind of graphs, because that's exactly what this is done from. Next slide. So now I want to give you a few tips from what we have learned. And how much time do I have? My clock's gone. So while you're doing your informal observation, and I'm cleaning, that's not your IP. I'm talking about your DON, your administrator, and it can include your IP. But that's not with her pencil on paper out there doing actual number audits. I would ask you to look at what your CNAs are doing when they're doing vital signs. I'll give you a little clue. When I'm in the building, I'll watch a CNA go in and out of 3 rooms. Then I'm going to walk up to that CNA and say, how often do you clean that equipment? And they're going to tell me they're cleaning it between every resident. And then my next question is, what are you going to clean it with? And I will tell you 9 times out of 10, they have no wipes or product to clean that piece of equipment. So that tells me, and you can see the deer in headlights go off on their face when they can't show me what they're cleaning it with. So that's a quick, easy way to tell whether your shared equipment used by clinical services are being cleaned appropriately between each class. And as Regina said earlier, I don't know how many times I go into a clean storage and it's nasty. The equipment's dirty, the area's dirty. So I want to emphasize, open those doors. Go in those rooms. Don't just walk up and down the halls. Open those doors, look in there. And one thing that drives an OIP crazy is I don't know how many times I see shared equipment stored in a shower, a usable shower. So that means the humidity's high in there. You have residents in and out in there. That is not an appropriate storage for your shared equipment. It's either a shower or it's plain storage. It's not both. So look to see, and things just creep in there because people are hunting a place to put things. Okay? That's the reason it's so important that Regina talked about. Make sure that your sign on the doors are very clearly marked what it is and that you're maintaining that space for what it's said purpose for. Is this wheelchair on the right? I want you to notice that one of the things it always says is condition of your upholstery and your mobile equipment should not have any tears, cracks, or other things. And this was in a clean storage room. And you can see it does have cracks and tears on the back of that wheelchair. Okay. Another thing, if it's shared equipment, be very careful that the fabrics you choose are cleanable and the surface that you select should be clean and a product that you can actually clean. It's going to hold up to disinfectants too. So those are some of the things you need to look at. If you have wood counters, countertops, and wall surfaces, those should be all in good conditions. You can't clean when the particle board between your countertop, the laminate surfaces is gone, and you can see the boards, that's all porous surfaces. You should not have those. Walls that do not have paint, it's just visible sheetrock, sandy, you can't have that. That has to be cleaned. Sometimes I've gone into rooms where tiles are missing on the floor and it goes off, and for some reason, nobody replaces those tiles. Those have to be replaced. That concrete, unfinished, is not a surface that can be cleaned. You should have no tape or sticky surfaces. Watch your staff, and I'll have to point out wound care nurses is where I see this a lot, touching their wound care carts with dirty gloves, going in and out of those carts. So keep your eyes out for that. Make sure that your housekeeping staff have separated. If they're using cleaning rags, you don't use the same cleaning rag to clean your rooms with. Make sure that there's very clear separation between bathroom products and the rest of your room. Changing mop heads and water. The policy should define if you're using microfiber, how often those are cleaned. If you're using a mop and bucket, how often are those cleaned? And this is just a point of thought for if you're an administrator. If you're using a mop and bucket, and your utility closet is on a different unit, and I bet your policy says on normal circumstances that mop water should be changed between every 2 to 3 rooms. I would really look at that process. I don't think that your housekeeping would ever get through if they had to go to a utility closet and change those out every 2 to 3 rooms. Okay. So you might want to investigate the microfiber products. I don't have any dealings with anything in microfiber, but just make sure that those are changed between each room. They carry the whole lot with them. It makes meeting that criteria so much easier. And you can tell when you walk down those halls, look at that mop bucket water. And doing it a lot, I would say at least 80% of that time, that water is brown, not clear. So that tells me people are not changing that water as prescribed. Always watch your staff coming in and out of your quarantined or your isolated rooms. Those should always be done last. Okay. If it's for C. diff, not just for COVID, but anytime, those rooms should be last. And the last thing that I see that really doesn't have much to do with cleaning and disinfecting, but just remember that biohazard items cannot be stored in a clean area, which includes your medication room, your nourishment room, your clean equipment room. All of those are clean areas. Anything that's labeled biohazard has to be stored in a dirty area and the room has to be clearly identified that they are storing biohazard subjects in there, like with the emblem on the door. So just make sure that those things are in place. Next slide. So in summary, create policies and procedures to ensure a systematic approach. Plastic bags, clean before, tags, all of those. Increase the frequency of cleaning and disinfecting, particularly for high touch surfaces, especially during COVID. Audit proper cleaning and disinfecting of the facility's environment as indicated in your policies. What your policies say is what should be happening. Make sure that you're following EPA microbiology products that are effective against whatever organism, right now COVID, or if you're .C. diff, that second list. And make sure that you follow the manufacturer's instructions. And when I talk about using hospital grade products, that's really important. That's not the Clorox that you go down and buy from Walmart. There's a difference. So make sure you provide ongoing education for your housekeepers and your other staff, not just your CNAs. I noticed I put PT, speech therapy, all of those other people. And make sure that you consider specific housekeeping staff to affect resident care units. And one of the things that it keeps going out of my mind that I wanted to mention. Well, I thought it, anyway, next slide. This is the contact people for Georgia Public Health, HAIT. If you have any questions, we're here to help you. And also Alliant is here to help you with, if you would like some more information on the PIP project, I'd be glad to talk to you about it. And, I like to do things that are going to be beneficial for you. Okay? I think does anybody have any questions?
So Teresa, Regina, and Dr. Gar all are available for questions. And Amy or Erica, do we have Paula, do we have any questions in the chat box at this time? Hearing none, if you have any questions following this, I have dropped the link in a couple of times already, and that will give you all of this information along with the links. Teresa, Regina, we thank you so much for being with us today, along with Dr. Swati Gar. We want you to save the date of September the 16th at 11 a.m. These offerings for office hours are always the third Friday of the month at 11 a.m. So please save the date for next month. Again, we want to thank the Georgia Department of Public Health as well as the University of Georgia. Without them, we would not be able to bring you all of this information today. And last but not least, we ask that you join us on our social media platform at Alliant Health Solutions. So at this time, we thank you for staying with us. We know that we've gone over, and we thank you for staying with us during our technical glitch. It seems like that some electricity has gone off up in the Atlanta area today. But thank you for staying with us. And again, thank you to all of our speakers for a great job and a lot of information shared that will be available on our website at the link that I posted in chat. So you can pull off any of this information, the audit tools, or anything that you absolutely see or want to use. And please don't hesitate to reach out to Teresa, Regina, myself, or anyone at Alliant Health Solutions, as well as Department of Public Health through the grid that we gave you with those contacts. At this time, we will conclude today's offering, and thank you so much. Have a great weekend.
Sorry, guys, I couldn't find the.
Teresa, I can't throw us over into a chat session, so hold on just a second as folks are going off.
Okay.